Welcome everyone to the first Victorian Comprehensive Cancer Centre Breast Cancer Grand Rounds for 2021. I hope everyone has had a good break over Christmas and January and feel refreshed and ready for the year ahead. We've got an excellent Grand Round series coming up for the year. We've taken advantage of our the move to remote, and everyone's getting used to virtual events by having a number of speakers from interstate and international, as well as today's talk. I'll introduce Alastair Thompson shortly. Keep in mind for your diary, we have a breast cancer symposium, breast cancer in young women, where our guest speaker is Anne Partridge from Boston. On 24th, next Grand Rounds will be Christabel Saunders from Perth, talking about some technology for breast margins. And then on 10th of March, we have Mark Robson, Head of Medical Oncology at Memorial Hospital and a leader in cancer genetics, who'll be talking about germline genetics into cancer care. So a lot more coming up, and we look forward to a really excellent seminar series. Before we start today's meeting, I'd like to acknowledge the country. So I'd like to acknowledge the traditional custodians of the land on which we are all meeting. I would also like to pay my respects to elders, both past and present, and extend that respect to other Indigenous Australians present online. A reminder that the chat function is available, and you can register questions as we go, or at the end there may be some opportunity to actually ask a question live. And now I'd like to introduce our speaker. Professor Alastair Thompson is well known to many. He's a close friend and colleague of mine. He was a graduate of the University of Edinburgh, holds fellowships from the colleges of Edinburgh and well as the American College of Surgeons. He was a clinician scientist in the UK for 2 decades and then moved to Houston, Texas to MD Anderson in 2014, and more recently moved across the street in Houston to Baylor College of Medicine, where he's Professor of Surgery. Alastair really is an international leader in breast cancer. He was one of the PIs of well-known trials, including MINDACT and Christine. He has a long history in the area of DCIS, being chair of the Sloan Project that I believe he will talk about, as well as PI of the Comet study in the US. It truly is an honour and a pleasure to introduce Alastair Thompson, and we look forward to your presentation. Thank you, Alastair.
Thank you so much, Bruce. And I really appreciate the privilege of being able to start your series this summer, fall, I guess, as it is in Australia. And it's a real pleasure to talk with you today. For those of you who don't know me, I'm very much an advocate of doing these sorts of talks over the internet, and let's see whether I can get this to work or not. There we go. So I graduated a long time ago in a land far, far away. As Bruce said, I spent a happy 20 years or so in Dundee, in Scotland, migrated to MD Anderson and now Baylor College of Medicine. And as you can see, as the buildings get shinier, so the hairline recedes. What I'd like to do today is bring something of a European and Texan flavor to some considerations about DCIS, and really to think about some of the diagnostic methods, some of the risks and concepts around active surveillance, and then how to use some molecular determinants to look for outcomes and choose our therapies for DCIS. So many of you will know that DCIS is classed as a non-obligate precursor for invasive breast cancer. It's almost always these days detected on breast screening. As you can see, the classic pepper pot and salt appearances of DCIS on breast screening. And in the United States, there are some amazing numbers of women every year who are diagnosed with DCIS, mostly through breast screening. And of course, breast screening does show up a number of other problems, LCIS, radial scars, and sclerosing adenosis. And so we need to distinguish DCIS from some of these other problems, which are not premalignant in the way that DCIS can be. So what is DCIS? Well, that's a very simple question, which is actually not quite so simple to answer. It's something of a bucket diagnosis, which allows us to class this neoplastic process as either low risk through to not quite so low risk of progression to invasive disease. And you can see at the bottom of this slide some of the risks for progression: age, palpability, the grade 3, comedonecrosis, and the extent of the DCIS, which classically we associate with higher risk of progression. And we'll come back to those. Now, some of the risks are related to grade, as we've said. We did this prospective study through the Sloan Project. The Sloan Project is a prospective cohort study of now some 15,000 women with screen-detected DCIS in the United Kingdom. And amongst those many women, there were 89 who'd had DCIS on core biopsy, proven DCIS, but for whatever reason did not go on to have surgery. And you can see that over about an 8 to 10 year period, those who had high-grade DCIS often progressed to invasive disease. Whereas those who had low-grade DCIS, it was pretty rare for them to progress to invasive disease. And that chance of progression was actually reduced by the use of endocrine therapy. And I think this discrimination about that DCIS, which is more risky for progression, and that which is low risk, and how we can lower the risk, is something of a theme that is a modern theme we need to come back to. Now, there's been some interesting work, retrospective SEER data, which perhaps classes the risk as a little bit lower of that progression. But you can see this study based on Duke University is really quite worrying in that there are a high proportion of women who die of other things, something I'll come back to in a moment. A quarter of the women who did not have initial surgery had died over the time course, the 10 years of this. But in this study, they were really not able to confirm our discrimination between high-grade DCIS having a high risk of invasive cancer. Yes, there was a risk compared to lower risk DCIS. And then many of you will be aware of the work from Sagara, who's now a surgeon back in Japan, who when he was in Boston, produced this elegant SEER data analysis, looking at grade and the risk of progression to invasive disease. And just highlighting that top right-hand figure, you can see that the 10-year disease-specific survival, whether you had surgery or whether you simply had surveillance and no surgery for the DCIS, when it was low risk, low grade, was almost identical. And then more recently, the Duke group, Reza and colleagues, presented this work at the San Antonio Breast Cancer Symposium. If I can just guide you through this wasn't using the SEER database, this was using the National Cancer Database, which is probably a better data set than SEER. They had 20 patients from each of 1,300 sites where they did a propensity modeling to try and mitigate all the covariates and looked at the difference between surveillance with endocrine therapy, breast conservation therapy with endocrine therapy, or with radiotherapy, or both. And the bottom left figure here, you can see that surveillance, that box at the top of the figure, really had quite a high risk of invasive breast cancer with simple surveillance compared to the full treatment of breast conservation, endocrine therapy, and radiotherapy. But as encircled there in the middle of that cartoon, you can see that surveillance with endocrine therapy actually was less risky than breast conservation alone in terms of the chance of developing an ipsilateral invasive breast cancer. Now, thinking about grade and comedonecrosis, how good are those? We've said they're risk factors for progression, but how good are we at working with those as clinicians to try and discriminate risk? So here's a study that is just being published at the moment, which 3 specialist breast pathologists from the Netherlands, 3 specialist breast pathologists from the UK, and 3 from the United States each looked at 425 examples of DCIS. And you can see from the 9 pathologists on the top right that there was really very little discrimination and very little agreement as to who had grade 1 in blue, grade 2 in green, and grade 3 in that pinky orange color. And even if you just discriminated lower risk, grade 1 and 2, from grade 3, you can see that you spin a coin and you take your choice as to what the grade might turn out to be. And as you'll see in a moment, this has been a huge problem for some of the surveillance trials, trying to work out who is low risk, grade 1, or even grade 1 and grade 2, versus who's higher risk with grade 3. So maybe grade's not quite as simple surgeons like myself would like to think. What about comedonecrosis? Well, there's been 2 consensus guidelines as to what in 1997, there was a conference that decided that any central necrosis, as you can see in that left-hand figure, would be considered comedonecrosis. And then 20 years later, the pathologists decided that it had to be an area of expansive necrosis. And so with Stu Snit and colleagues in the northeast of this country, there was a survey conducted which asked a group of 35 pathologists, which would you say constituted comedonecrosis? And you can see for yourself that amongst specialist breast pathologists, there was really no consensus agreement. So if I'm asking the question, is comedonecrosis associated with increased risk of invasive breast cancer, it's really not clear what should be the definition of comedonecrosis based on this specialist pathologist guidance. So the risks of progression from DCIS to invasive disease. Well, here's a paper that really caused a lot of worry to a lot of people. Again, the National Cancer Database, large number of women, and you can see that both DCIS and invasive disease was examined. And they were worried about the delay from diagnosis to surgery. And of course, this came out in 2020 when here in the United States, we were getting pretty uptight about COVID, and many of the hospitals were shutting down and patients with DCIS were being asked to just wait, and in some cases wait with endocrine therapy. And what they essentially showed was that there was an increased hazard ratio with each delay interview for risk of death or for risk of invasion. Now the risks are slight if you look at the hazard ratios, but real. And the problem that many have found with this thoughtful study is that if you look into it in a little bit more detail, you'll find that the age under the age of 50, which we know is a risk factor, increasing distance to some sort of facility that would treat DCIS, and being Black or Asian, and a number of other risk factors were also associated with delays and the risk of death. So perhaps worryingly, but maybe not quite as worrisome as we had initially thought, that delay, perhaps COVID-induced, perhaps as in your country, not COVID-induced, is something that we need to be a little bit thoughtful about, but it may be a reflection of other concerns rather than the actual delay itself. And then there's a question of the upgrade of DCIS to invasive disease. We know from the literature that as many as 1 in 4 women, the DCIS may be upgraded to invasive disease at the time of surgery following on from the biopsy. And there are a number of tools that have been used, not least of all, increasing the size of the biopsy. And you can see that a 7-gauge vacuum-assisted biopsy is quite a big chunk of tissue to take out with the needle that's used. So overall, again, this Duke group with Lars Grimm, radiologist, leading the study, demonstrated that the overall upstage to invasive disease using this vacuum-assisted biopsy technique was about 17%. However, in those who might be eligible for the sort of surveillance trials I'm going to come to in a moment, the upstage rate was much less at only about 6%. So what about outcomes? Well, this study from the Sloan group, just recently published and also presented at the San Antonio Breast Cancer Symposium, we looked at what happened to women who had an initial diagnosis of screen-detected DCIS and then subsequently developed either on the left-hand side, ipsilateral DCIS once again, having had breast conserving surgery originally, or developed invasive disease on the right-hand side, again, having had breast conserving surgery only. And you can see that the risk of DCIS developing again in the same breast sort of stayed pretty constant at about 1 in 200 over the first 5 years, and then tailed off quite substantially between years 5 and 10. Whereas on the right-hand side, you can see that the risk of invasive breast cancer in the same breast after breast conservation surgery alone was a steady 1 in 200 year on year for at least 10 years. And then the other information that we presented at the San Antonio Breast Cancer Symposium, which I think is perhaps of interest as well, is what happens to these patients who have screen-detected DCIS. Well, at about the 10-year mark, about 11.6% of them have died, but not many of them have actually died of breast cancer, perhaps 1 in 8. And in fact, other cancers of the pancreas, of the colon, of the lung, are similar in proportion to those of an age-matched group. So what I was going to do is just briefly talk about the active surveillance trials and how this initially was driven to some extent by the media and by advocates for not doing a mastectomy for everybody with DCIS, certainly in the United States. And these trials were driven initially by Adele Francis, who started the UK trial. Sadly, Adele died 3 years ago of pancreatic cancer, and we all miss her. But her legacy has been a number of trials around the world which are addressing the problem of active surveillance for low-risk DCIS. The first trial was her trial LORIS, low-risk DCIS, which was set to randomize patients between surgery with radiotherapy and endocrine therapy versus active surveillance. Sadly, this closed to accrual when it transpired we weren't going to get enough patients going in to meet the target of 932 patients. And it closed earlier last year, really because there were difficulties with getting consensus between grade 1 for the 3 breast pathologists, specialist breast pathologists that were looking at the samples before the patients could be randomized. And that's something I alluded to a little bit earlier. The Dutch trial, the low-risk DCIS or LORD trial, required vacuum-assisted biopsies. Again, it was for grade 1 only and had annual mammography in it. But once more, it really failed to recruit very well and has been converted to a patient preference study, which has been going since August of last year. And of course, the Comet trial, which is a comparison of operative to monitoring and endocrine therapy trial, which I have the privilege to be co-principal investigator with Shelley Huang and Anne Partridge, who you're going to hear from at the next, and I hope a rather less problematic from the technology point of view talk. This Comet trial, you can see by following down the chart there, allows patients with low-risk DCIS, including those who've had surgery with a positive margin, to enter the trial. And after written informed consent, the patients are registered and randomized either bottom left to guideline concordant care or to active surveillance. Now, we assumed that not everybody would accept their allocated treatment, and that's been built into the statistical analysis. And we've also assumed that most patients may want to consider endocrine therapy, whether they're in the guideline concordant care arm or the active surveillance arm. And what's important is that we've tried to exclude young patients under the age of 40, anyone with a mass, and the higher risk, if you like, DCISs. And our initial endpoint is going to be perhaps a safety endpoint, the 2-year ipsilateral invasive disease progression, rather than the perhaps more interesting to most of us involved in DCIS, 5, 7, and beyond years, what happens. Built into this is clearly a strategy to monitor the patients every 6 months for those who are in the active surveillance arm, every 12 months for those who are in the guideline concordant care arm. And there's fairly fixed but rather thoughtful ways of checking up for any progression, and that will be dealt with, as you can see here. Now, what's been quite satisfying from a translational medicine point of view, and this is where you who are listening, if you have some ideas as to what we could test in the Comet trial, might want to have particular interest, is that the images have been collected centrally at an organization called Quark. Almost always they're mammograms, serial mammograms, occasionally there's ultrasounds and MRI. And the tissue has been available from 82% of the patients, half in the form of blocks, the other half in the forms of 20 sections up to 5 microns. And we've also been collecting Strec blood so that we can do things potentially like cell-free DNA. So just to summarize those clinical trials, you can see that there are 3 randomized trials, plus there's the 4th Loretta trial in Japan, which is a single-arm trial where all women under active surveillance receive tamoxifen. And at the moment, we're at the 630 mark of the 1,200 that we're aiming to recruit. That's been hit substantially by COVID, but interestingly, every month on month, despite COVID being quite impactful in the United States, patients have continued to be recruited. So what about how we use some of these determinants for outcomes? Well, we've already talked about some of the clinical risk factors, and it's my privilege to work with some very fine clinicians, both surgeons, reconstructive surgeons, and I'm indebted to the imaging team and pathology team I work with so that we can enter patients into trials like the Comet Trial. But one of the important things, as many of you know, is the intraoperative assessment, where we're trying to get clear margins, involved margins being a risk factor for recurrent disease. And you can see the very familiar to many of you processing of taking the specimen, X-raying it, inking the margins, and then slicing and repeating the X-ray that we go through, often intraoperatively. What is, I think, a very novel approach is to use for intraoperative assessment an ex vivo optical coherence tomography technique. And for those of you like me who wear spectacles, this OCT technique is actually used to examine the back of the eye, examine the retina as a standard of care, certainly in ophthalmology and opticians in the United States. And what it does essentially is do a sort of 2 millimeter depth, almost mini ultrasound. And as you can see on the right-hand side, the H&E showing the DCIS, and below that, what had been the OCT image of the DCIS. And we're in the process of developing the AI algorithms to try and recognize these spots when we scan the whole surface of the specimen. And probably the middle of 2021, I have the privilege to be leading a national trial in the United States, which is going to test this technology and ask the question, can we reduce the 25–30% reoperation rate that's almost standard in the United States to perhaps the 8–6% that some parts of the world manage to achieve? So many of you have got interests in the cell biology side of things, and particularly for DCIS. And some nearly 30 years ago, I guess, I had the privilege to work with a colleague in the United States, Diane Radford, and we published some research showing that P53 was mutated and overexpressed in DCIS, and that was the important thing to target. 20 years later, using much more sophisticated next generation sequencing, similar sort of concept was coming up, but without really any targets that we could manage and improve our treatment of DCIS. Many of you are familiar with the Exact Sciences tool, the what used to be Genomic Health Oncotype DCIS tool, which looks at a number of variables and has been fairly rigorously tested by people like the late Larry Solin and Eileen Rakovich in Canada, and is associated in terms of the score you get with what's going to happen to the patient in terms of recurrence of DCIS on the left or development of invasive breast cancer in the same breast. But reflecting on what I've been saying earlier in the talk, you can see that the age of the patient, the tumor size, and other clinical features actually were quite important when you do a multivariable analysis of this Oncotype DCIS technique. And so others have come along and asked the question, well, if that's not working quite as well as we would wish, maybe the important question is not what's going to happen, but can we influence whether a patient should or should not receive radiotherapy? And here you'll see the monograph for the 4 or 5 randomized trials, which demonstrated that radiotherapy significantly reduces the chances of local recurrence and particularly of invasive disease recurrence. So as many of you know, there has been this decision score from Prelude DX, which has come to the fore based on some initial studies done as much as a decade ago, showing that COX-2 and P16 might reflect prognosis for DCIS. And you can see what's different about this score is that it's got built into it already some clinical pathological factors, as well as some of the sort of things you'd suspect, like hormone receptor, HER2, and stress response and proliferation genes to try and give us a decision score where low is good. And if you have a score of 3 or more, you've got a greater risk of something happening. And this, as you can see from this initial publication, which I think is beginning to be backed up with further evidence, you can get the sense that if you have a low score on the left-hand side, then probably the benefits from radiotherapy are not great. Whereas if you have a higher score for your decision-making, then you'll see that there could be real benefit, maybe as much 1 in 10 patients benefiting from radiotherapy. And this scoring system, this Prelude DX decision score, is being rolled out at the moment across the United States, in the middle of these 3 scoring systems. You'll know that Eileen Rakovich has been very involved in both the 12-gene DCIS score, but also came back to the San Antonio meeting and demonstrated that the original 21-gene invasive recurrence score might be worth reconsidering. And so I would agree with her that one of the things that is unanswered at the moment is just how good are each of these 3 scoring systems at helping us with what really matters, which are the 3 or 4 boxes on the right-hand side. And I think we've yet to really drill down and find that out. So what about other molecular determinants? Well, this is where I have the great privilege to be part of a large international organization, which I'm delighted to say colleagues in Melbourne, including yourself, Bruce, have been joining the Precision Prevent Ductal Carcinoma In Situ Invasive Overtreatment Now project. And it reflects one of the grand challenges that Cancer Research UK put out about 5 years ago, answering the question, we hope, when is cancer not really cancer? So this international consortium was awarded 5 years ago now, quite substantial funds to try and identify biomarkers to distinguish DCIS patients with a low risk of developing invasive breast cancer from those at a high risk. And part of the aim was to try and reduce our overtreatment of many women, which is clearly happening. It's got a consortium from around the world of a few characters from the Netherlands, the United Kingdom, and those of us in the United States. But actually the really important people in this are ringed in red there, who are the patient advocates that got this off to a flying start. You'll know that trying to set up a consortium like this is terrifically difficult. And this horrible mind maple indicates the number of data sharing and material transfer agreements that we've had to put in place. And most recently, I'm grateful to colleagues in Melbourne who've also agreed to contribute data and materials to trying to answer this question. But you can see it's an enormous task to get everybody to allow their data and materials to be transferred across the world. Some of our early results were to look at those DCISs that had not progressed on the left-hand side of this chart, the primary DCIS and the matched normal tissue, comparing those two on the right-hand side of the chart, the DCIS that had progressed either to form further DCIS or, more interestingly, to form invasive disease. And you can see that we were able to get, at least initially, quite a number of samples where we could look at RNA-seq, SNP arrays, targeted sequencing, and indeed have made tissue microarrays. And you can see the breakdown that we were interested in ipsilateral invasive disease, which I think is the real key thing here. Also ipsilateral further development of more DCIS, but also as some sort of control for what was going on in patients, the contralateral invasive and DCIS disease, and a number of patients, the bottom line, who hadn't developed any further DCIS or any invasive disease at about the 10-year mark. And some of the initial results, which I'm very happy to share with you, are shown here with, for example, the RNA-seq using the sort of technologies that PAM50 and Chuck Peru have popularized over many years. You can see that the cases, those patients who developed invasive disease, really did separate out whether they were luminal A, luminal B, or the normal PAM50 subgroup. according to their expression by RNA sequencing. You can also see that some of the mutations that you might expect to see in DCIS, my beloved P53, second only to PIK3CA, but a lot of other mutations that maybe you wouldn't have necessarily spotted were coming up as we looked through. But if you get a little bit more stringent, as many of you would expect me to do, when we use a targeted system of 121 genes and a low 5% allele frequency, you can see that the top 5 or 6 genes, as shown here, were P53, PIK3CA, ATM, NF1, interestingly enough, and IGF-1 receptors. But if you become a little bit more stringent, if you will, then PIK3CA is the one gene that stands out. And that may give us hope for the future, that if we can find a low toxicity, targetable PIK3CA drug that is possible as a preventive agent, maybe there's a way that we can prevent DCIS progressing to invasive disease in patients who've had DCIS originally diagnosed. Some of the places we've been less successful include looking at the microenvironment and using Vectra, which is a multiplex immunohistochemistry platform. We've really failed to find in 160 patients or thereabouts any signals from lymphocytes and macrophages that are signals that we can confidently say are associated with invasive disease. Looking at the calcification, as well as looking at some of the features of the mammography that's been used to diagnose this DCIS, we're beginning to get some signals that may guide us, may help us to use AI to find out those patients that are more likely to progress or less likely to progress. Again, this is early days, and there are many a DCIS that's going to have to be further analyzed for its calcium and what the subtypes of calcium are before we're going to be confident this could be useful. And then some of the mouse modeling we've been doing, the MIND model, the intraductal injection of DCIS into a mouse, has been really quite useful at trying to generate models of DCIS, where the DCIS cells injected into the mouse mammary gland down the duct actually form DCIS, and over a period of sometimes 6, 9, 12 months, as you can see on the right-hand side of the screen, they form DCIS, but sometimes they progress on to invasive disease. And then the other model, which I've been very keen to work on with my former colleagues at MD Anderson, particularly Gigi Lozano and Rhiannon Morrissey, who's a PhD student there, is to model DCIS by using a P53 mutant model. And those mice, after about a year or so, start to develop DCIS, and some of them go on to develop invasive disease. So the mouse modeling for DCIS is actually beginning to look rather more exciting than it has over the last 10 years or so. And what I'm hoping we're going to be able to do is put together all these different components and integrate them in such a way that we can prospectively validate whatever we find in the clinical trials that you've just been hearing about from me. So, in conclusion, when is cancer not really cancer? Well, I give you one answer there, but you can tell that we're having some real difficulties in trying to nail down which DCIS matters from a patient's point of view. Diagnosis, when you think about chomedonecrosis, when you think about grading, is not as simple and straightforward as a surgeon like myself had thought it would be, talking to pathologists initially. Some of the trials that are ongoing have run into difficulty, but I do believe the Comet trial at least will deliver some real evidence as to whether active monitoring for selected patients can be just as good as surgery. Molecular diagnostics, whether it's the DCIS scores from Exact Sciences, whether it's the Prelude DX decision tool, they are here to stay, but I sense they're probably not perfect just yet. And I hope that we'll do better in the future. And by getting some better molecular discrimination of DCIS, it will aid us clinically to making better decisions for our patients. So with that, I'd like to thank some of my colleagues who've been really very helpful at getting some of the DCIS work done here since I moved to Baylor St. Luke's Medical Center and the Dan L. Duncan Comprehensive Cancer Center. I have my email address there in case any of you want to reach out to me afterwards. And with that, despite the hitches which we've managed to perhaps overcome eventually with the technology, I would like to thank you for listening to me. Thank you very much.
We do have a little bit of time, and I'm sure there are some questions. So often the easiest way is for people to just put it on the chat. We do have some. So a question about the impact of chemo prevention on subsequent events.
Yeah, a great question. And as you probably know, only about 13% of patients in the United Kingdom in that prospective Sloan study were on endocrine therapy. And the absolute reduction in risk of developing same-side invasive disease was of the order of 4%. So equivalent in many ways to the absolute reduction of 4% we also saw from radiation treatment after breast conserving therapy.
And 4% is over how many years? Is that 10 median?
That was over 6 years median.
Right, okay.
So there's a very real benefit over that short time of getting endocrine therapy.
Okay. So I had a question while the paper you presented on the impact of delays, there were two things. The one was mortality, which seemed, there was mortality, then the other was the association with delays of upgrading to invasive cancer, if I read it correctly or understood correctly.
Yes.
And I wondered whether that was dependent on the grade of DCIS on core biopsy. So was that more evident in high grade than in intermediate or low grade?
Do you know, I can't remember that level of detail, I'm afraid, Bruce. And I think it's a paper that's well worth going back to and reading. It's now available free online. And Wade et al., I think, have been very provocative in publishing that. I think their analysis is good, but I think there are reasons why the every 30 days increases your risk and the upgrade rate and the mortality impact. There may be other reasons for that, because certainly the numbers being quoted were perhaps more worrying than the data that we would have expected from things like the prospective Sloan Project.
Yeah. Okay, we've got a question from Belinda. Do you think it is possible there will be more invested or investment in prospective molecular decision aids for DCIS compared to invasive disease, given that they may have potential for de-escalating therapy even more than what we see of their use in invasive disease? And also related to it is another question: what impact do you think DCIS heterogeneity, up to 75% in some studies, confound your molecular predictors of recurrence and how to overcome?
So the first of those is about the tools that we may be able to use moving forwards. And as everyone knows, there's the Exact Sciences Oncotype DCIS, and there's the Prelude DX decision tool. They're still, I think, not fully as comfortably validated as some would want. And I think in the future, what we're going to need, Belinda, is to move to having tools that are useful upfront in terms of who needs surgery versus who doesn't, who needs endocrine therapy and is going to benefit from it versus who doesn't. Rather than at the moment, we're a little bit stuck with, if you're going to have surgery, if you've already had surgery, do you need radiotherapy or not, which is what the decision Prelude tool is about. So I think there's room for several better molecular predictors of what's going to happen. And I have to confess that the second question has gone completely out of my head.
The impact of heterogeneity. The molecular predictors, how confounding will the fact that a case of DCIS may look different according to which area is selected?
Yeah, and that's a great point. The heterogeneity within DCIS, we're beginning to learn about. One of the best investigators, in my view, of this is a young man called Nick Navin, who is doing single cell work. And what we're doing as we take out DCIS at Baylor is transferring it over the road to him at MD Anderson so that he can do RNA analyses, including quite deep RNA analyses and DNA analyses, and sort of get the subpopulations of cells, not purely the epithelial cells, but some of the other populations like the myoepithelial may be as important, perhaps not, but equally worth consideration. So I think as we unravel the heterogeneity, not simply of the ductal cells, but also of the other cell populations in the environment of the DCIS, I think we're going to learn much more, as you know. Thank you.
Another question: what else is taken into account when working out what treatment options for those with DCIS such as family history or genetic faults?
Yeah, I think one of the most important things is to have a face-to-face conversation with the patient. So what that means is that if there is a clear family history of the woman is quite young, under the age of 50 in our practice, we will probably suggest genetic testing. Now, genetic testing is very easy, very available, very cheap, relatively speaking, in the United States. So it takes about 10 days to get a panel back of 1947, however many genes in the US at the moment. And I know that's exceptional compared to many other current countries in the world. But many of our patients will wait for that genetic testing, and that may drive them towards a bilateral mastectomy, and in many ways, more importantly, towards a bilateral oophorectomy and removal of the tubes as well. So I think genetic testing probably not being used as much as it might across the world to inform what we do with DCIS, but is one of many clinical factors that we have to include and consider in managing individual patients.
An observation, I think in the decision RT, grade wasn't one of the factors, histological grade. Is that the case? And it seems a little surprising.
Yeah, so if you look at the decision RT, I don't know whether I can get my screen back up for you, but age, the extent of the lesion, the margin status, and the palpability were the 4 clinical pathological factors. Now, I wonder whether the grade is actually taken into account by 2 of the molecular markers they were looking at, the proliferation with Ki67 and the cell cycle with P16. So as indirect rather than direct visual markers of grade, I suspect that they've included some measure of what would be equivalent to grade otherwise.
Okay, one question from Cara. Did your RNA-seq on the DCIS with and without recurrence indicate that the immune microenvironment or stromal cells are important?
No.
And if so, can you inform us?
Yeah, no, it didn't. And the reason for that, which you're going to think we should be kicking ourselves over, is that we either microdissected with a laser or macrodissected by direct vision the DCIS from the surrounding tissues. So all that surrounding tissue, it's not lost because it's been put into a separate set of pots, if you like, and potentially will be analyzed in the future. But the focus has been very much on the epithelial cells. So any of those of you in Melbourne who are particularly interested in the non-epithelial stromal cells, I think have probably got an advantage right now over that precision group.
A question from me back to about the issue of family history. When we are discussing cases in our multidisciplinary meeting, DCIS is seen as less of an indicator of the likelihood of germline mutation. And I know that BRCA1 is rarely associated with DCIS. What about, has that general understanding changed over recent years? Are some of the new genes more associated with DCIS, or is DCIS still not really a hereditary condition?
So great question. And I don't truly know the answer, because I think the more we learn about the genes, there's probably 167 of them, of which we'll check for perhaps 19, maybe 47, depending on which panel we choose to use. I don't think we have a full knowledge of which genes are responsible if there is a hereditary component to DCIS. So we've tended to downplay the genetic component of DCIS compared to, for example, triple-negative breast cancer. And I think as we move forwards, as we learn more about DCIS, recognizing, as you saw from that targeted gene panel, that there can be any number of different mutations and abnormalities, which probably aren't inherited, but maybe some of them are. I think we need to explore and find out a lot more before we can be certain what the genetic impact is, inherited genetic impact is, on development of DCIS.
Okay. All right, we've come to 1:30. If there are any final questions, please type them in. But we've been treated to a wonderful talk covering many aspects of DCIS, and we congratulate you on the work that you've done over the years. And it's good on behalf of some of the Melbourne investigators who you've helped to engage. It's really wonderful to be part of that collaboration. We look forward to continuing the discussion, and we look forward even to having you over here in person sometime.
Thank you so much.
But with that, I'd like to thank you, and a reminder to all the audience of the Young Women's Forum on Friday week, and then grand rounds again in 2 weeks, which will be Christabel Saunders from Perth. So thank you very much.
Thank you, Bruce. Bye for now.